Hello, I'm Paul Tate and welcome to the respiratory team here at St Richard's Hospital. We are 3 consultants, of which I'm one. We also have Dr Harpreet Ranu and Dr Bethia Bradley. We're based on Ashling Ward, and it is a busy ward, but you're well supported by excellent nursing staff, and that's led by Caroline Bailey, our ward manager.
Hi, my name's Caroline. I'm the ward sister of Ashling Ward, which is our respiratory ward. We support you in all sorts of different ways, far too numerous to mention at the moment, but my office door is always open. You'll get a little chat when you first get here and tell you that I'm a bit like a mother hen and I tend to be a bit overprotective, but that's only because I care. We look after our patients to the best of our ability and have a very high standard of care.
We have quite a mix of patients and most are admitted via the emergency floor, but we also have some planned or semi-planned admissions direct from home. On the ward each morning there's a consultant presence, there's a consultant ward round every morning. That consultant of the day will see half the patients and any new patients that have appeared overnight. And then the following day it's an alternative consultant seeing the other half of the ward, and again any new patients.
Hi, I'm Helene, I'm one of the GP trainees. So this is Ashling Ward, so where we're predominantly based. Through here is the doctor's room, and that's normally where we do most of our work. So in the mornings we normally come in at about 8 o'clock, and that's where we can get the lists and everything ready for the ward round. At 8:30 there's a multidisciplinary team meeting where we've got the ward sister, the physiotherapist, occupational therapist, and the social services representative, the care coordinator for discharges, as well as the doctors, and we just go through all the patients together. At about 9 o'clock the consultants come onto the ward, and at this point they cover 2 of the 4 bays, and then the rest of the doctors will cover the rest. Normally the ward rounds finish at about 11-12 o'clock, and normally then in the afternoon predominantly we do the jobs. Occasionally there are oxygen assessments that need to be done. This happens a couple of days a week, and the patients come in at 2:30. So one of the junior doctors also has to assess them in this respect. Any other ward attendees tend to be things like chest drains, which the registrar will deal with. That's pretty much what we get up to during the day. If you can get to clinics, which doesn't happen that often, but if you can get to clinics you can go if it's a bit quiet on the wards, but otherwise you're predominantly based here and we don't have any outliers elsewhere.
My name's Ketan, I'm the registrar on respiratory on Ashling Ward. So my average day often involves doing the ward rounds in the morning. It's sort of with the junior doctors, so the consultant would do one side, I'd do the other side of the ward. So that's usual mornings, and the afternoons are often in bronchoscopy or being involved with teaching or doing some admin work or getting involved with the radiology department to practice ultrasound. And we have 1 clinic a week which is on Wednesday mornings with Dr Tate. The on-call rota is set up by Hazel, who's our rota coordinator, and it's all online on the intranet. With regard to booking leave, it's sort of, you confirm it with your consultant, make sure you've got enough cover on the wards. So long as we have a minimum of at least 3 junior doctors covering the ward, it should be fine to take leave. And booking it's quite simple, you simply let your consultant know and inform Hazel, the rota coordinator, who will then authorise it for you, and that's for annual leave. Study leave, you go through completing a request form and hand it in at CMEC.
I think you gain a lot of confidence in sort of managing people that become hypoxic. So one of the big fears when you're starting an F1 is whenever someone's oxygen sats drop is how do you deal with that? That's quite scary, they're not breathing. And just getting a bit more comfortable with how you escalate that and who you can turn to for help is always a good big plus to know the respiratory nurses, know the respiratory physio or the critical care outreach team, so that if you are on call and someone's becoming acutely unwell, you know where to turn. And yeah, it's also generally just quite good for having a good group of seniors. That there's 3 SHOs, there's the registrar, there's 2 or 3 consultants that you can always turn to get more advice and learn more about what you're doing.
Whilst on the team, you will be allocated a consultant to be your clinical and perhaps also your educational supervisor. So we hope you'll take the opportunity to make the most of that support. We do have regular direct clinical contact, but we do also organise dedicated meetings to go over the e-portfolio, but also to go over any issues or concerns that you may have. It can be a busy ward. We have quite a variety of patients. We do have some patients that require non-invasive ventilation in the form of CPAP or BiPAP. We deal with a lot of chronic conditions such as emphysema, and also we have quite a number of patients with lung cancer. In terms of learning opportunities and support, I think there's plenty on the ward itself and also out of the direct clinical environment. On the ward, as I say, we do have consultant-led ward rounds every day, so I hope there's opportunities for learning and feedback directly on the job. In terms of other opportunities, we have lung clinics happening most mornings of the week, which you're welcome to attend at any stage, as a supernumerary just to observe. We have a lung cancer MDT on a Monday lunchtime, again welcome to attend. There's a formal medical grand round meeting on a Wednesday afternoon, and we also have a combined cardiac and respiratory educational meeting on a Friday lunchtime.
Throughout the week, you generally have Wednesday afternoons on alternate weeks are your trust-based learnings. There'll be lectures on here or workshops all at the education centre that you just attend, and they're mandatory, and so you have to sign in and sign out for those, but they do take your bleep off you, so it's okay.
So the key learning is essentially procedural and getting hands-on experience with putting in chest drains and using the ultrasound probe, which we have on the ward. The other aspects of when you're on Ashling as a trainee is getting a bit more aware of how to use BiPAP and the indications for using it. And I think that's something you develop with time whilst on Ashling ward and getting an idea of it.
We certainly hope you'll get good and varied experience as part of a member of the respiratory team. There is the opportunity to learn more potentially about pleural procedures and chest drains. We hope you'll also learn more about controlled oxygen therapy and also non-invasive ventilation, particularly CPAP and BiPAP use on the ward. You'll also get significant exposure to patients with lung cancers, and I hope you'll learn something of the multidisciplinary team approach to such problems.
The team is very good on Ashling. In terms of the nursing staff, they're all very supportive. They all know exactly what they're doing with regards to BiPAP, chest drains and everything else that's involved with the respiratory team. With regard to the juniors that we have is often a mixture. Within the SHOs we have core medical trainees, general practitioner trainees and F2s, and then we always have 2 F1s with us as well. In terms of training for the juniors, we often involve them in chest drains and other procedures and supervise them as they're doing that.
We work in close conjunction with the nurses who are really helpful, and we tend to also work in close conjunction with the physiotherapists and occupational therapists, and everyone's pretty much based on this ward. There's a real multidisciplinary team approach with our patients.
There's lots of opportunities to get feedback from different levels, so you can turn to your SHOs who'll be there and get brief procedures done, or go through those with the nursing staff quite easily as well. But if you want sort of more formal case-based discussions, often if you've clerked a patient on your on-call and they end up on the respiratory ward, you could then speak to your registrar or the consultant when they see them on ward round and get feedback formally done for your portfolio or just for your own learning.
Feedback's a really important thing because it helps you to understand what you're doing and how that's perceived by other people. And unless you ask for and receive feedback, you might not know that. So one of the things we're encouraging people to do is simply ask. When you're doing something on the ward, or whether you're with your consultant or your colleagues, you can ask them, would you mind, when we're finished, giving me some feedback? And most of the time people will do that. They'll say, yes, of course, I'd be happy to. But if you don't ask, it might not happen. And the other thing that's really important is sometimes it's important to give feedback. So the people that are teaching you might not really understand how you perceive them, how you feel they are. It really helps if you can say, would you mind if I gave you some feedback about how that went? Particularly if it's something good. If you give good feedback, it makes everyone feel better. It helps our morale, it helps engagement, so people really want to help you and you can help them. So just say, when we've finished, can I give you some feedback? And I'd be really surprised if they said no.
The trainee doctors can always come up to me for feedback with regard to procedures that I might have observed them doing, or with regard to sort of case-based discussions. Often the junior doctors on the ward get first dibs at doing chest drains and having me observe them, but junior doctors from all around the hospital are more than welcome to come onto the ward and be observed doing chest drains.
With it being a medical job, you're allocated all your leave at the start, and there's a rota there that's all done by Hazel, the coordinator. If you want to change anything on there, then you have to just go through your consultant to say there's cover with the other juniors on that day, so there has to be 3 juniors on the ward. But then it'll be okay, you email Hazel and she'll just change the rota. If you need to take time off, if you want a bit of day that you want to take off as leave, you're meant to be on call, you'll need to arrange for someone to cover that on call, which might just involve swapping a day with them and covering their on call at another point. If you're sick on the day, you just call in, let your consultant know, send a message to your team so that they've got a bit of a heads up as well, and then formally email or call the leave coordinator so that they can try and arrange cover if needs be. On the ward and on all the wards in the hospital, you'll use an electronic prescribing system called JACK or EPMA, and it's quite simple. You sort of just search for the medication you want to give, and it'll normally automate to a standard dosing of that, but you just need to adjust that to what you need. Simply click it and it'll go through. It can take a little bit of getting used to how you make it do slightly more complicated prescriptions, but there is a helpline, and normally someone else, one of the other juniors, will have worked out a way of doing things, so you can just ask for help from anyone around. The microguide is an online app, or it's also accessible through the internet, and it just gives you advice for first-line antibiotics or alternatives if they've got an allergy to those, for most of the common conditions you'll find. Top tip, especially early on in the year, would be to just ask everyone whenever you're uncertain. So if you're giving a medication and you're not quite sure how long an infusion runs for, ask the nurses. If you're prescribing something for the first time, don't worry about just turning to one of the SHOs and saying, just want to double check something, because they're all really nice and approachable, and I'll just be like, yeah, that's fine, or they'll be able to give you a sort of bit of impromptu teaching about what you should be doing in this circumstance. And that's just an easy way to build up some confidence so that later on down the rotation or later on in the year, you can then give that advice to someone else who hasn't been in the same situation.
Choosing respiratory at Chichester, the plus points are that there is you're the only registrar, so you're not fighting with another registrar to get time in the bronchoscopy department or with chest drains, or trying to get the consultant's attention. So it's one of the plus points. And the other thing is that a lot of the consultants here are approachable in comparison to other hospitals, so that's 2 main plus points to coming to Chichester for respiratory.
The respiratory department it's a really nice place to work. The team at the moment is excellent. Consultants are all really approachable. There's 3 SHOs, a registrar and 3 consultants that are all really nice and easy to turn to, so there's always someone just at the end of the phone or on the ward who you can actually speak to about anything. And they're all really nice and friendly, and the nurses are also a good group, so it's nice.